Hello everyone, my name is Kacie Whalen, and the purpose of this presentation is to discuss my DMP project, Nonverbal Tools in the Emergency Department to Bridge Communication Barriers. My committee members for this project were my chairperson, Dr. Heather Deering, and my community member, Rachel Moore. The role of adequate communication across healthcare organizations has been identified as a critical aspect of successful healthcare outcomes. There have been several advances toward improving communication in healthcare settings. However, several barriers still contribute to a lack of satisfactory communication outcomes. Many people view communication as a fundamental skill, so there's a lack of structured quality improvement initiatives to overcome these barriers, especially in the emergency department setting. Nonverbal communication tools have been shown to improve patients' outcomes and safety and promote employee satisfaction. Literature evidence supports using whiteboards in hospital settings to enhance staff member communication and information sharing. The Agency for Healthcare Research and Quality also has presented another nonverbal tool. This tool is called the Ticket to Ride Handoff tool, and it provides an overview of essential information for healthcare staff to review to promote a safe patient transfer. Implementing nonverbal communication tools in healthcare can improve patient safety, satisfaction, and outcomes, while also enhancing team member knowledge and overcoming current obstacles to communication in the emergency department environment. So the purpose and aim of this project, it was a quality improvement project that focused on improving communication in the emergency department settings with patients and interdisciplinary team members. The project utilized two nonverbal communication tools to share information with patients and team members to communicate more effectively. The purpose was to determine if nonverbal communication tools improved communication skills and patients' perception of communication and improve patient safety, satisfaction, and outcomes, while also enhancing team member knowledge and perception of teamwork in the emergency department. My PICO question was as follows. In healthcare workers and adult patients of a rural emergency department, does implementation of a nonverbal communication tools compared to verbal communication alone enhance interdisciplinary team communication and understanding, and improve patients' overall perception on communication, information sharing, and knowledge? Background on this project, insufficient communication impacts, in the emergency department specifically, impacts patient care and increases hospital costs. Hospitals in the United States lose an estimated $12 billion a year due to poor communication or miscommunication among healthcare providers. Communication with patients must be accurate, complete, and timely to prevent these avoidable costs. Aside from costs, ineffective communication leads to suboptimal patient outcomes and often leads to confusion and uncertainty upon discharge. 1 in 5 patients return to the emergency department within 30 days due to uncertainty regarding their condition. Many cases of ED revisits are avoidable with competent and accurate communication to patients and their families. Communication within the emergency department is particularly difficult due to limited time, heavy workloads, and frequent interruptions. These factors directly correlate to why the ED setting is a high-risk environment and a danger to patient safety. A central component for safety is adequate team member communication. Team member communication in the emergency department should be multidimensional and occur before, during, and after patient treatment. Team member communication not only assists in promoting patient safety, but also increases staff satisfaction and the team culture. So the two nonverbal communication tools that I chose based on this is still the background of my project, but these are the two nonverbal tools I chose for my project initiative. So whiteboards were chosen. They are cost-effective tools that enhance patient engagement and satisfaction through a visual aid that triggers nonverbal communication. Whiteboards also facilitate healthcare staff communication through appropriate and necessary information sharing. The Ticket to Ride tool provides safe patient handoff to ensure the person taking charge of the patient has the appropriate information to promote patient safety and well-being. The tool also provides essential information to team members that can assist in decreasing delays in care. Communication tools aim to advance the ED environment and improve the overall structure and function of the environment. Promoting strong and quality communication is a simple task that helps improve satisfaction for team members and patients. The significance of this project, obviously communication is an integral part of the nursing practice in all settings. Patient-centered care is a long-held fundamental of nursing practice, achieved partly through practical communication skills. Identifying communication barriers for healthcare nurses is critical to promoting patient-centered care and creating positive outcomes. In a busy healthcare environment, communication must be multidimensional and include more than verbal cues. Communication tools in the ED help promote effective communication through verbal and nonverbal approaches. Implementing a timely and efficient communication process can directly affect patient satisfaction, safety, outcomes, and promote job satisfaction in nurses. So, review of the literature. I focused on three main components when reviewing my literature, and those were barriers to communication, implementation of nonverbal communication tools, and studies that aim to improve patient outcomes. So the literature search was conducted on EBSCOhost online search database. Specific databases were selected to refine the literature research, including Academic Search Complete, Cumulative Index to Nursing and Allied Health literature, and Medline Complete, and eBook Medical Collection. The initial search presented 6,395 articles, and the search was narrowed using the Boolean operators and specific phrases, and the end result was 17 relative articles. So 3 major themes were identified and integrated for the integrated review of the literature. The first major theme was barriers to communication that were identified in studies. Several of these studies presented similar challenges that were perceived as barriers to communication, especially in the ED setting, such as the high demand environment, the high acuity of patients, and complex coordination of care. Also, the lack of coordination between interdisciplinary team members and ED staff. The second identified theme was implementation of nonverbal communication tools. The theme identified and connected several different studies that implemented traditional whiteboards, digital whiteboards, or redesigned old whiteboard templates to help improve overall communication. A few studies utilized the communication assessment tool TEAMS, or the CAT questionnaire, which was identified due to its use in my DNP project. And then the final identified theme was studies that demonstrated improved patient outcomes overall. Several studies showed improved patient outcomes with enhanced patient satisfaction and outcomes, improved quality of care provided, and also improved coordination of care and improved team dynamics across the health span. The literature review provided considerable reliable evidence for the DNP project and provided a solid foundation for continued research. The ED is a challenging environment that ultimately leads to poor communication and information sharing, and nonverbal communication tools such as whiteboards have substantial evidence behind them that deems them essential to improving communication in healthcare settings. The theoretical framework I used for my project focused on was represented by the Institute for Healthcare Improvement, the Plan, Do, Study, Act framework. The PDSA cycle is a component for the model of improvement that aims to test and adapt change to ensure they result in a desired improvement. These are valuable, or this framework is specifically valuable for quality improvement research, and it fit my quality improvement study very well, and it was used to help build my project. So methods, my DNP project was a quality improvement project focusing on communication strategies in the emergency department setting. 2 surveys were used to collect quantitative data from voluntary patients and facility team members. The primary aim of data collection was to understand the perceptions of communication in the ED from patients, ED staff, and interdisciplinary team members. Therefore, the study did not collect demographic data from patients, and it was entirely voluntary to complete these survey questionnaires. In order to keep the project completely anonymous, an implied consent was used in place of a signed consent. Both instruments that were chosen for data collection were validated tools that were used in previous studies and demonstrated valid results. The surveys were administered before the implementation of the nonverbal tools and after to determine if the tools made a difference in communication perception. Throughout the study, ED staff and interdisciplinary team members were educated through emails and through daily huddles on the purpose of the study and on the progress of the study to ensure adequate understanding and participation. My data collection instruments, as mentioned in my previous slide, 2 of them were used for both pre- and post-intervention data collection. Both collection instruments were drafted before the IRB for data retrieval and approved for pre- and post-data collection. So the communication assessment tool, TEAMS, was chosen to gather data from patients to evaluate patient perspectives on communication effectiveness with the emergency department staff. This survey is a psychometrically validated instrument that is composed of 15 questions focusing on patients' perceptions of communication and the quality of the medical staff. The Teamwork Perception Survey is a part of the Team Steps protocol presented by the Agency for Healthcare and Research Quality. This survey is 35 questions that aim to measure staff perceptions of team structure, leadership, situation monitoring, mutual support, and communication. Both tools were scored via 5-point Likert scales. So the design of the study. This study took place at a critical access hospital in the rural Midwest. It was in the emergency department setting specifically, and only 16 beds were used for the quality improvement intervention due to 2 of them being trauma bays and the others being dedicated psychiatric health rooms. Therefore, the whiteboards could not be implemented because they could be removed from the walls. So the sample in my project, demographic data, of course, was not collected. My subjects for the CAT survey included 80 patient participants pre-intervention and 77 participants post-intervention. My subjects for the TTPQ survey, I had 48 participants pre-intervention, 52 participants post-intervention. It was a randomized method used to recruit participants who met the inclusion criteria for the study. And then again, all participants were voluntary, and given the aim of the study, no demographic data was collected. So the design of the study, pre-intervention data was gathered to understand communication effectiveness before initiating the nonverbal tools. After a sufficient number of responses were collected, the nonverbal communication tools were implemented in 16 ED rooms. ED staff and interdisciplinary team members were informed of the quality improvement project during meetings, daily team huddles, and through emails. The healthcare team was provided with opportunities to voice concerns and ask questions, which supported quality advocacy of the data by allowing ongoing feedback. Post-intervention data was then collected using the same survey questionnaires to determine if there was a significant difference in communication perception. So here's an example. These are the ED whiteboards that I specifically created for my emergency department setting. As you can see, it focuses on the care team, pain, and then it uses a checklist instead of having to write out each thing, which was helpful for my nurses. Instead of having to, write down the orders every single time, they were able to just mark what was ordered and then again what was completed. And this is a picture of the Ticket to Ride tools that I also created for this project. It focuses on, of course, the patient's activity level, if they need oxygen, language barriers, responsiveness or mentation, sensory deficits, and then other special considerations that nurses may want to know. So for data analysis, the study was a quantitative exploratory study that used a randomized method to recruit participants who met inclusion criteria. Again, demographics were not obtained from participants because they were insignificant to the research study. Inclusion criteria was specific to ensure valid and reliable answers from participants and decrease the risk of skewed results. The surveys used a 5-point Likert ordinal scale. For each participant, each numerical value of all responses was summed up to create a total score representing the participants' survey scale. Therefore, each participant had one number that represented their score for data comparison. Each data point represents the survey scale for each participant in the following surveys. So as you can see, these are my data results for the pre and post survey results for the CAT. The CAT survey, again, was for patient participants to fill out. Each point there is a single participant's survey score. And by looking at pre and post survey scores, you can see that there was not a significant change between pre and post survey results. And then here is figure 2, which is my pre and post survey results for the Team Steps TTPQ survey. And this was the survey that was filled out by ED staff and interdisciplinary team members. Again, as you can see, there's not a significant change between my data points. So the results of my study, the study's results demonstrated that there was no statistical difference between pre and post intervention survey scores for the CAT, P equals 0.195, or the Team Steps survey, P equaling 0.170. The independent samples TEAS test ran for both surveys indicated that the use of nonverbal communication tools in the ED setting did not improve patient perception of communication or improve patient did not improve interdisciplinary team communication or the perception of teamwork. An independent T sample test for the CAT survey revealed there was no statistical difference between pre-intervention scores, as you can see in my slide there. M equals 51.3, standard deviation 8.123, and then the post-intervention. And again, for the Team Steps survey, it also revealed there was no statistical difference between pre-intervention scores and post-intervention scores. The power analysis ran for both surveys were also considered low, as you can see in that last bullet point there. So this slide demonstrates the test of normality. The independent samples TEAS test was used to determine if there was a statistically significant difference between patient and staff perceptions of the quality of communication before and after implementation of nonverbal tools. To run an independent samples TEAS test, certain assumptions must be made. One is the dependent variable must be normally distributed. The Kolmogorov-Smirnov normality test and the Shipro-Wilk normality test were run for both pre-survey scores and found significant p-value less than 0.05. Technically, this does violate the assumption of normality. However, there were no indicated outliers that were found. Therefore, the independent samples TEAS test was robust enough to provide correct outcomes considering the sample size. So there is the two tests for normality, and in the next slides you will see my histograms, which demonstrates the lack of outliers. So this is histogram for the CAT pre-intervention and post-intervention. As you can see, there are no indicated outliers when running the independent samples TEAS test. And again, this is the Team Steps pre-intervention and post-intervention histograms, just demonstrating there are no indicated outliers and that the independent samples TEAS test was robust enough. So the independent samples TEAS test was used to compare pre and post data for data obtained from the CAT survey for patients and pre and post data obtained from the Team Steps survey for staff members of the facility. The standard deviations are similar in the data sets that are being compared. Therefore, equal variances are assumed. Neither the CAT nor the Team Steps demonstrated significant results, considering the p-values were greater than 0.05. There was no significant difference between pre and post intervention measures. The effect size shows the difference between two data sets measured in standard deviations, and the power analysis for each data set shows the probability of finding a difference given that a difference occurred. The power analysis was performed on both sample groups, comparing pre and post intervention scores, and the power analysis for CAT and the Team Steps survey were both considered low. So limitations to this study. A significant limitation associated with this study was the inconsistent use of nonverbal tools by the ED staff and interdisciplinary team members. The ED is a challenging environment to implement new policy changes, and staff members did not consistently use the tools daily. Reasons for inconsistent use being short staffing, ED members juggling several tasks at a time constraints due to the fast-paced environment, and then just general forgetfulness. Also, the limited time frame of the study was another limitation that caused restraints. After the appropriate approvals were made for the project to proceed, the time frame of data collection was slim, making the project more rushed than initially anticipated. And the time constraint did not allow staff and interdisciplinary team members enough time to get used to the nonverbal tools before post-intervention data was collected. So discussion, one barrier noted after the project implementation was time constraints, as discussed earlier. ED staff members are trained to work quickly and effectively with minimal interruption, and adding another task to their day with the implementation of nonverbal tools was more difficult than anticipated and posed a barrier to consistent use of the tools. Another barrier that was identified was the short staffing throughout the facility. The ED environment is stressful, which causes high turnover rates, and short staffing has been a struggle for the facility for many years, as is throughout the United States right now. Short staffing in healthcare negatively impacts communication due to overworked staff, missed information, rushed information, which could potentially impact patient care and safety. Clinical significance, I went over that one, of course, was to address communication barriers within the ED setting and provide patients and interdisciplinary team members with more modes of communication. And then, of course, successful implementation of the program could demonstrate improved perceptions of teamwork, team structure, and communication from interdisciplinary team members. So the use of back to facilitators and barriers, the use of a paper format screening tool allowed for screenings to be convenient for the participants and the researcher. Providing the screening tools in a paper format and using a Likert scale survey increased participation and allowed for immediate results. Providing the survey in a paper format also allowed patient participants to complete the survey immediately after their ED visit, which allowed for thorough and honest results. Another facilitator was the cost effectiveness of both nonverbal tools and the needed supplies. All needed supplies and the boards were all bought by the researcher themselves, very cheap, very manageable, and reusable. So unintended consequences was, of course, the delayed IRB approval that was discussed in my previous slide. The time change delayed the project's completion and collection of the necessary data. The delayed approval led to smaller time frame from 5 months to 4 months, which did cause a strain on the project. And then another unintended consequence during the intervention phase was the lack of consistent use of the communication tools by the ED staff members. And they were not used accordingly, so some of the results were not accurate. So implementations for practice, the Quality Improvement Project did establish barriers to communication in the ED setting, and identified the need for improvement in communication strategies. The desired vision statement for the project would be to improve communication strategies with nonverbal communication tools to enhance the perceptions of communication with patients and interdisciplinary team members. Bridging the gaps of poor communication can create a structured environment that enhances patient safety and understanding and promotes teamwork satisfaction. A future project idea or future development of digital whiteboards working with the electronic healthcare system could allow information to flow in automatically and improve utilization of the tools. So, in conclusion, the independent samples tease test ran for both surveys demonstrated that the use of nonverbal tools in the ED did not improve patient perception of communication or improve patient satisfaction. The statistical analysis demonstrates that nonverbal tools did not improve interdisciplinary team member communication or perception of teamwork. The results of the study demonstrate a need for further research on the topic of nonverbal tools in the ED setting to improve overall communication. The data analysis results elicited for the pre-intervention and post-intervention scores after the implementation of nonverbal tools did not support the aims of the project. There have been several previous studies that demonstrated whiteboards in medical facilities significantly improves overall communication with patients and interdisciplinary team members. So furthermore, studies have revealed that patient satisfaction scores are increased with the use of nonverbal tools. I think with further research on the topic and a longer time frame of this study, we would see an improved inpatient outcomes and interdisciplinary team outcomes. There were several patients and staff members who did verbalize their appreciation for the tools. So I think in the long run, we would eventually see some statistical change. And then, of course, if there are any questions, please feel free to reach out to me via direct email, phone call, or on the Canvas messaging system. Here are the references for this presentation. And that concludes my presentation on my DNP project. Thank you all for listening, and I hope you enjoy watching the video.